morning, good afternoon, good evening, depending on where you are in the world. My name is Annette Dale Pereira, and I've got the pleasure in chairing this very important seminar on opioid substitution treatment, or OST, literacy and rights. So we're going to spend the next hour and a half with you. We've got a great lineup for you. We've got an overview of the project coming from Christos Anastasio, and I always get that wrong, and I'm so sorry, so I'm going to call
no
Christos A. Christos A. will give a fabulous overview of the project. We're then going to hear how the project is unfolding in 3 countries in Europe, and then we'll have some reflections on the project from Dr. Christos K. We'll then have time for questions and answers. And if anybody's got any questions all the way through this, please do use the chat function. We will be monitoring it, and then we'll bring in their questions through there. A little bit about intro for myself. So I've been working for many years in substance use treatment in the UK. And then in the last 5 years, I've been working mainly internationally, mainly for the United Nations Office on Drugs and Crime and the World Health Organization, primarily on helping to try and improve the quality of treatment for drug use and drug use dependency, drug use problems. Now, there's some really interesting things, I think, happening at an international level. So for the first time, we've got some great international guidelines that have been agreed by all 192 member states. They're not perfect because there are consensus documents agreed by 192 different countries, but they do stress the importance of everybody having access to high quality treatment that needs it. And within that, they stress the importance of having good quality pharmacological treatment, including opioid substitution treatment, sometimes called opioid medication assisted treatment, methadone, buprenorphine maintenance, etc. And the international guidelines stress the importance of every system in every country having access to this very, very important medication. Some not so good news is that the coverage of drug treatment around the world is still quite poor. The global average is 1 in 8. Sadly, in many countries, it's less, especially in places like Africa. It's nearer to 1 in 18. In Europe, we are luckier. We do have, as a region, the highest coverage of drug treatment of anywhere in the world, but we've still got a way to go. And we know that the quality of many types of drug treatment isn't good enough. And sometimes we don't have evidence-based practice. We haven't got a good enough dose. Some services don't uphold human rights, and some do not offer the key modalities and interventions. I was working last month in Pakistan, and in the whole of the country, they still do not have access to OST, and they're looking at how to do that. So we're doing better in Europe than many parts of the world, but there's still work to do. Now, empowering people who use opioids, increasing awareness of evidence-based OST treatment, and educating people on what they should expect as a human right and in terms of the medication and support they should get is critical to ensuring the quality of treatment. So I fully support this initiative. It's an excellent project. So let's hear more about it. So I'm going to hand over to our first speaker, Christos A. I'd be very, very delighted if you would tell us about the project and give us an overview. You have the floor.
Okay.
Thank you.
Thank you. I want to welcome all to our first webinar from this series. I want to wish you all a nice month, and that today is April Fool's Day, and be careful, don't get fooled. And I'm starting to describe the project. The OST Literacy and Rights project is based in a collaboration between Europut, a donor pharmaceutical company called Camerus, and the 3 pilot countries, Germany, Sweden, and United Kingdom. The project is managed by me, Christos Anastasiou, from Pyrnaps, Greece. One of the key elements of the project was the development of an OST client guide called OST. We are in this together. This is a guide about treatment of opioid dependency from people who have lived it. The OST client guide consists of a technical briefing on opioid dependency, OST medication, and the process of OST assessment, treatment initiation, dispensing, supervision, and review. It also includes standards of meaningful participation in client-centered care. The document further includes a troubleshooting section that helps address key problems that may arise in delivering an OST care plan. The OST client guide was written by Matt Saswell in consultation with the wider project team. The Europut resource was strongly influenced and drew by a sister resource written by Bill Nace and other Canadian priests from British Columbia. The project is being piloted in 3 national settings. With this project, Europut sought to empower people with opioid dependency to raise their knowledge about the treatment system, treatment options, and the rights of the people in drug treatment. This support peers to talk in an informed and educated way when advocating for their rights. The OST project also includes country consultation with peer and professional stakeholders in 3 pilot countries. The purpose of consultation is for partners to review the good practice standards described in the technical guide and compare them with the current practice in their national codex. Consultations are also a platform for discussion about opportunities to strengthen OST services and increase meaningful participation of people with opioid dependency. Pilot countries are in different stages with regard to this part of the project, which corresponds with a specific country context. Germany has already completed the consultation, whereas UK and Sweden we could conduct this year. The OST client guide has allowed Europut an opportunity to work with key stakeholders in national OST system who can use the resource within their quality management systems. The guide has been a critical resource in process and demonstrated a key lesson that by putting technical resources in the hands of the country drug user group, those groups can then advocate and work towards a change at a national level. OST Literacy and Rights project has proven to be a great success due to the continued 2021. Talks are currently underway about translating OST leaflet in the other countries, Norwegia, Greece, and elsewhere. While Europut hopes to pursue an OST project also in other European states. Also, we are starting from today. This is the first webinar series about the peers and we call it peer works. And I want you to welcome it's our first webinar. Thank you very much. That's it for me.
Christos, thank you very, very much for that excellent overview of the document. We've got a few comments and questions coming through, but that was a great overview. Thank you. Somebody asked whether a recording of the seminar will be available, and the answer is yes, we will share. We're sharing the guidance document itself. OST, we are in it together. If you can see it here, it's shared in the chat. That's great. A question for you, Christos, from Lynn Jeffries. She said, what was the BC guide called? She missed that in your talk. Can you answer that?
What was?
The BC guide called. I'm guessing BC is British Columbia?
Yeah.
Yeah, the British Columbia. Okay, it's by Bill Nails, and the name it's I think methadone something. Wait,
I've shared it in the link. It's called the OAT handbook. Is what it's called, and we've shared it in the link as well.
Thank you for that. We've got a collective response from you on that one by our dear friend Bill Nellis. So thank you for that question, Lynn. That's excellent. Great stuff. We've got some more things coming through. Yes, great material. Thank you, Christos. So you've got some good comments coming through. Somebody said, this is a fantastic resource. Is it okay for me to share on Twitter, or is it being formally launched? That's from Joe Schofield is saying that. So good responses to this already. So excellent.
Thank you all.
Thank you very, very much, Christos. Now, I think it would be really interesting to go and hear some of the experiences of the rollout for some countries. So the first person that I would like to invite to speak on this is Dirk Schaefer, who will talk about rollout in Germany. Dirk, would you like to take the floor?
Yes, I will start. Can you give my camera, Roberto? Roberto, stop my camera. Okay, now it works.
And we can see you now.
Yes, hello guys. Thanks a lot for being here today. We were very excited when we were invited to be one of the countries to implement this new project and this new leaflet, because in my view, in the beginning, I thought it is not that easy to have treatment guidelines for different European countries, because many of us had different structures for OST treatment, different regulations, also different medications. So I was very excited if this works. And what we did then is that, as Christos told you, Matt was very helpful to set up the frame of the project and a first version. And with this first version, I presented that at the National Addiction Conference in November in Berlin. There were a few hundred doctors and also staff from psychosocial care and from other disciplines, and we discussed that on that level. And after this, I brought it to the jazz network I'm working with. We have 20 local groups in Germany. You all know that. All of them called Jazz Junkies, ex-user, and people in opioid substitution treatment. And they made very important changes in the paper for Germany, because, as I told you, that we have different structures and also different medications. And what my colleague said was that it made no sense to speak about medications we didn't have in Germany, because no one knows that. It make no sense. So we have the same basis, the basis brochure, the same text, but we have some special things for the countries inside. So, you know, we have this levomethadone in Germany, we put it inside. And so After this, we discuss that with the doctors and with people who use drugs in our network. It comes to the next step, that it go to the printer, and now we copied 1,000 issues of that, and distributed that to different doctors in different regions, but also to drug service organizations who are responsible for psychosocial care. And that is the very important thing of this new project, that it is usable for all kinds of disciplines who are working in OST treatment. It is in the first line for us as people who use drugs, who are working in advocacy or in other topics, that we can show what are the international guidelines made by drug users looks like, but they are also usable by doctors and for staff in psychosocial care, because they are parts in it also for these topics. And so I'm very happy that we have now a common version for all over Germany, or for the 3 countries we have, and we can use this version also for the special German situation with our special regulations, that we brought both these things together. And what I heard from drug user organization and also from drug services, that they used this brochure, they gave it out to the people who want to read and use it. And we have now, I think, 2,000 copies for Germany, and we have a distribution system that it comes in all regions in Germany. And so I think it is a very important step that we, from the perspective of people who use drugs and people in opioid substitution treatment, start a process to have OST guidelines and treatment guidelines, but they are usable for all others too. And it is not only the perspective of people who use drugs, which is inside this project. It is also the perspective from doctors and from other people. And so it is very helpful, very useful, and very important. And the main goal and my wish is that we can have it also in some other European countries, or in all European countries where drug user organizations are, and that they can also work with. And we show in the 3 countries that it is possible to have European guidelines. They are usable in specific countries. And I'm very happy to be part of the project, and thanks a lot for your attention.
Dirk, thank you for an excellent overview of what's happening in Germany in terms of the rollout. And I think you made some fantastic points there. So I thought it was really good that you said that the first line use of this document is for people who use opioids, but you stressed the importance that it is usable for all kinds of disciplines in terms of people who are providing treatment for people who use opioids, doctors and psychosocial care. Got more than 2,000 copies printed, that it's been culturally adapted. And I think that's one thing that the development team stressed. They recognize that's really, really important. Yeah. And that you've got a fabulous distribution system by the sound of it. So, I mean, well done.
Thank you. In addition, if I can mention one thing, I think the title of the project and also the leaflet is very important. OST, we are all in it. And with this, we show that not only we as people who use drugs and would take OST are in it, but we are all in it, with doctors and with staff for psychosocial care and for other disciplines. And I think that is, we gave the hand to others to come with us to go the next step. And that's very important, I think.
No, I think I'm really pleased you said that message of partnership and everybody needing to get behind the evidence and human rights-based practice is a fantastic message for everybody.
Okay.
There were some comments and questions coming through as you were speaking. So people were immediately starting to ask about whether or not the leaflet is available in different languages. So there was Mariana was saying we need this in Poland in our national language. The need here is huge. We also had Antonino saying, is it in Italian? We also need it in Italian. And Matt, you were answering some of those questions, saying it's ready for translation. Do you want to say any more about that?
So the whole setup of the project is that the leaflet has been designed by this wonderful designer from Greece, and designed a model that allows us to create this leaflet that folds down to an A5, but also opens up into having this big table where you can look at the different OST products. And so we have a toolkit, and it's the aim is that this can be quickly translated and adapted to national contexts. The key for us is just having the funding to be able to roll out to this stage, because this project has been developed with a €10,000 grant. So we're delighted that it's been creating such demand, but we are also slightly daunted given the funding that we have behind this project right now.
That's great. Thank you for that elaboration, Matt. That's really, really helpful. Dirk, you were getting some great speech, Dirk, coming through on the comments there. Germany is one of the best OST systems was also said. Joe Schofield said, wonderful work. I'm sharing this with the Scottish Government's Drug Deaths Task Force and their medication assisted treatment group. Congratulations to everybody involved. I've got a question from Lynn. Matt, would it print on A3? And you've got, yep, we can provide a print ready model. So we've got lots of excellent feedback coming through. So Dirk, thanks again for that. I think that was a great example of cultural adaptation and rollout and working in partnership. So that's fantastic. Thank you very much. Next on the agenda, we wanted somebody to talk about the rollout in Sweden. Matt, did we get the speaker, or are you going to speak with this?
Yeah, so let me just quickly cover the situation in Sweden. We're really delighted to have Sweden in this project. It's very easy to run projects on harm reduction and drug treatment, where we always work with countries like Germany or France that have really, really strong OST systems. However, for us, it was really important to also look at the spectrum of experience in Europe. And Sweden is a country that we know has some of the most restrictive opiate substitution therapy standards in Europe. As soon as you use on top, if you're caught using on top, you're thrown out of treatment. It's a very punitive and hostile environment. However, there is a group of addiction doctors or doctors specializing in drug misuse or drug dependence who are really key allies and are really working to improve the OST system in Sweden. And we are delighted to have had a conversation with them, facilitated by the Swedish Drug Users Union, where we've started to talk about how can EuroInput, the Swedish drug user groups, and the Swedish Association of Addiction Professionals come together and create a resource that is useful in a Swedish context. Now, if you look at the main resource, we cover, I think, 5 or 6, depending on which country, different OST medications. In the UK, we've fought hard to make sure that all of those are described, even if they're not always available, because it supports our wider advocacy. However, in Sweden, we recognise starting to talk about dimorphine and long-acting morphine would be a hostage to fortune in the advocacy negotiations. So we've agreed a more restricted list of buprenorphine and methadone. And I think this process of tailoring to the national contract text is really important. Now, I don't want to overstate the partnership because we're still in negotiations. This is something that needs to be signed off by the wider society, and we need that. That also includes proper negotiation about the content of the leaflet. So we're really excited, and we're very grateful to Roberto Sandero from the Swedish Drug User Union for being the key leader on this piece of work.
Matt, thank you very, very much for that explanation. And again, you reinforced some great points there about cultural adaptation and tailoring it to national context and taking a very pragmatic approach about the kind of OST medication that you're talking about. So I thought that was an excellent point. We've got some great stuff coming through in relation to the chat. We've got a comment coming through from Mariana saying, the involvement of other stakeholders is absolutely critical and essential, doctors, social workers, etc. We've got agreement coming through in relation to that. And we've got recognition of what is universal to OST in all different countries. We've got a statement, nothing about us without us, but with involvement of other stakeholders. I think that's a lovely kind of comment to make that really communicates the spirit of the work that's been undertaken. So that's fantastic. Thank you very much indeed for all of those comments, and keep them coming in. We will read them out as we go through. Okay, next on the agenda, we're going to invite Lee Collingham to talk about the experience of the rollout of the project in the UK. Lee, welcome. And Lee's looking extremely smart today. Fantastic.
Well, thank you.
Yeah,
before this started, I really liked a lot of you. But since you've all spoke and gave amazing speeches, I hate you. You've said everything I was going to say. Anyway, for 20 years, I've been an advocate. I never knew about drug treatment before then. I did prison from the age of 11 till 32. And so I never knew about drug treatment. And then when I did and got to know it, I understood what was going wrong. Some people was being offered one sort of medication, and if you didn't have that, that was it. You didn't get treatment. Now, the other thing I noticed as well was a lot of friends were dying. And, excuse me, and I had to do something about that. Now, the only way I could think of doing anything meaningful as a single person is from the inside. So I started working with the local crime and drug partnership and the health shop, because I've always been a firm believer when money's tight, partnership working is when the most effective and best projects happen. When everybody's working together for the same objective, that's when the best projects happen. And this information leaflet we've done, I think, does that, because first of all, the name, we are all in it together, whether you're a prescriber, you're a patient, or you're a drug worker. And by everyone working together, it makes for a better working relationship, and it also makes for a better working environment. Because stats say that 60% of drug workers will take time off for sickness because of stress. Now, we don't want to give them a hard time. As OST clients, all we want to be is not ill. We don't want to be dictated to. We don't want to be sanctioned because we've missed this medication once. Now, the project started out as 3 different countries: Sweden, Germany, and the UK. However, Matt and I quickly realised that the UK is 4 countries, and each one of them is very, very different. For instance, in Northern Ireland, there's a lot of history and it's time-limited treatment. Thankfully, for the first 10 years I was doing advocacy, we had the NTA. And when we had them, everyone moaned about them. And since we've gone in and we've got a Conservative government and we've had the recovery model, it's only thanks to people like Matt, myself, like Annette in the UK, and a few others like Erin, that harm reduction and naloxone is still on the agenda. And now, thankfully, there's going to be a number of campaigns coming out that should have happened 10 years ago. We're actually doing work now that we did 10 years ago, we're repeating ourselves because doctors want to have control. Now, the whole point of this leaflet is to make service users aware of what's available to them and not give them unrealistic expectations, like saying, right, everyone's going to get diamorphine, because that's very unlikely. However, you're also going to get stuff like OST. The latest one now is Bividol, the long-acting, take it for months, you don't use on top. Well, not everybody has abstinence as a goal. I certainly don't. So anything that they're going to give me, especially something like naltrexone, they're actually doing harm to me. But what I found by having those conversations, I've got the changes that I've needed. It's took a long time, but like us, a lot of drug workers and commissioners are human, but their objective is money. My objective is keeping people alive, because I'm doing work on do not attend at the minute. And one thing I do know is dead people don't attend appointments. Now, luckily, we've had to take it slowly throughout the 4 countries. In the UK, we've always had quite a forward-thinking group of organisations, and there's a number come on board, quite rightly so, because the leaflet, it does what it says on the tin, and it gives realistic advice. And if everyone sang from the same song sheet, there'd be a lot less problems for everybody. So a lot of organisations in England have recognised that. Because of the politics in Ireland, I've reached out to a few people and it's taken a bit longer, obviously. In Scotland, we've had some amazing talks. And because of the, like you mentioned earlier, Annette, about their drug-related task force, they've done some amazing work in the last 12, 18 months that actually stand a chance of drug-related deaths in Scotland not being a record high this year. And thankfully, what has been happening, because it's election time, everyone's been getting behind Peter Crickham. I know it's sort of changed from what he's doing, but all of a sudden, he couldn't get insurance for his van because he didn't want it on the road, because he was providing the lock zone and the consumption room. And then all of a sudden, Nicola Sturgeon wants to meet with him. So, yeah, they're well on board, but obviously their system's different to England. So they've asked us, and we've said, yes, we'll make the changes, but it's as a partnership. We've done a lot of work on this document and we want to share it as far and wide as we can. But we also want to be part of any development of it. We don't want people to hijack it and do it for their own objectives. Because at the end of the day, a lot of us that have done it because we want better treatment for ourselves. We don't want to make money out of it. We don't want no awards. We don't want anything special. All we want is to be treated with equality. And that's it. And yeah, that's as far as much as I've got to say without repeating what everyone else has said, I'm afraid.
Lee, that's a fantastic overview that you've given there, and also sharing your personal experience there. We've got some very positive comments coming through the chat. Luana, great sharing, Lee. Regards from Portugal. There's you've really mentioned and brought home and reminded everybody of the importance of the issue of drug-related deaths and opioid-related deaths. As we know, this is increasing exponentially in many parts of the world. And you shared your personal experience about losing friends. And
it's been a good quarter. I've only lost 10 since December.
Gosh, I know, and we know. I mean,
that's the world we live in, though, and that.
It is the world that we live in, and yeah, no, absolutely. And sadly, we know that up to half of people who become dependent on opiates die of overdose and drug-related illnesses, and our lives that can be saved. We've got a reminder from, let me just from Sergio. when we opened the webinar, we should have mentioned the loss of our dear friends who've left and who must remain in our thoughts. Peace to our soul. I think many of us have lost friends and family members to overdose. I know I certainly have. It's a tragedy, and particularly where we can prevent these things. It's great to hear your testimony in terms of Scotland and the fantastic reception that the project has had up there, and particularly how well it's gone down with the drug-related death task force. As we know, was in dire straits, is still in dire straits around this. But if you can do anything to help them turn it around, that's fantastic. The other couple of things that I thought I'd mention that you
Scotland's 2, so 5. Oh, and Ireland's 2, so 6.
Absolutely. So we've got, absolutely. But it felt very much from the heart as well.
No worries. It was a privilege to be invited along to take part.
Oh, that's fantastic. And we've got we've got a comment. Well presented, Lee. Euro NPUD is delighted that Duncan Hill and Professor Katrina Matheson have championed the resource in Scotland. The next stage is a consultation with the Scottish people on opioid dependence, and we're hoping a co-branded tailored version will appear in Scotland. So we've got some great comments coming through there. So, and keep your comments coming through. And thank you for the reminder. I mean, the OST guidance, we are in it together. It does cover opioid substitution treatment, but it absolutely and rightly also covers responding to opioid overdose and naloxone, the life-saving medication that we need to get spread in every community, in every country in the world, if we can, and we're way off there. Okay, thank you very, very much indeed for that. I'd now like to invite our final speaker, Dr. Christos K, who's the Greek National Drug Treatment Coordinator part-time and who also works in OST treatment in the UK, to have provide some reflection on the project after having heard from all of our speakers and their experiences. Christos, over to you.
Thank you, Annette. I think you have already summarized and reflected quite extensively of what we have heard. But I would like to approach what I've heard from my relatively new position as the of how important is our policies and approaches to be based on evidence, scientific evidence. And this is really, really important because the history of treatment for addictions, either drugs or behavioral addictions, is full of philosophical, religious, other social approaches. And sometimes people approach the whole thing starting with I believe, I think, rather than that's what we know so far, this is where the evidence could take us, these are the pros and cons of whatever decision we're going to make at any level. And it's very important to say that the agenda in different countries has progressed in different directions. So, for example, in the UK, people who are using services are involved in research projects. In other countries, they are totally excluded. It is a very novel idea or threatening idea that people are involved in developing evidence. Wherever we don't have that, it's very important for people who are using the services to be involved in implementation of evidence which have been generated in a foreign country, in another country, or in their own country. It is very important to keep in mind also that we need to follow the principle of a balance between demand reduction and supply reduction policy. And that is crucial for countries outside Europe, where this balance has been achieved to a better or lesser level. And that's why, as you know, EU always stands to meet, as you all said, their aims and objectives at a particular time of their lives. Knowledge for professionals is also very important because professionals are not necessarily trained into the problem substance misuse. Even when I was a young professional in the UK, the average amount of time that doctors or psychiatrists had on substance misuse or addiction was very minimum. Things have been improved since then. In other countries like Greece, the exposure, the training that health professionals, doctors, nurses, social workers, they have on addiction is almost next to zero. And these people, these colleagues, these professionals need to implement and care for people without having the appropriate training. And lack of training creates defensive practices. But also knowledge shared with the people, with the population, with the communities out there will help for people to move away from dilemmas or polarized approaches into the social challenge of drug use. The third point, which your project is addressing, is the balance of power. Balance of power between professionals and people who are using drugs, between professionals and policymakers. And this balance of power is critical. It's critical because none of those groups know everything. So collaboration is crucial to improve the quality of treatment provided, the effectiveness of treatment, the improvement of public health, or the positive impact of treatment provided or policy developed for the well-being of the society as a whole. I'm a clinician, and I will just make a note about clinicians. Whenever there is, in whatever country, and my experience comes from UK and Greece, there isn't a protective framework for professionals to practice and provide treatment, those clinicians become very defensive. Because we need to find a balance between the rights that a service user has and people who are using services have by de facto, because about their life, but also the risks that professionals take within a specific legal framework to provide treatment. And we need to always keep that in mind, because it's something that I face day in, day out, both in Greece as a policymaker, discussing the vaccine commission. Point 4, you said it already, you emphasized it, adaptation of this excellent information flyer to the legal system and the framework of each country is of paramount importance. From one hand, the scientific evidence might be global and international. The implementation of this evidence needs to be specific to each country. Otherwise, it's not going to be acceptable. It is also important to distribute that knowledge, to empower the knowledge of professionals, as I said, and Germany has done really well into that, but also a vulnerable group of clients out there, of people out there, homeless people who don't know which direction to go, and they have preconceived ideas of what treatment might be, and so forth. And I'm talking about that because the major challenge I have as a policymaker in this is that how to approach the major issue of homelessness and drug use in the center of the 2 big cities. And don't forget, we shouldn't fall into the trap of divide and rule. And unfortunately, this is the trap we all fall into very easily. It's very easy to divide between professionals and people who are using services. Very easy to divide between the local community and the people who live on the streets. It's very easy to divide between different approaches, scientific approaches into drug treatment. Let's avoid this trap, and let's all be together into developing and implementing quality treatment approaches in each one of the countries for the benefit of the bigger society, of the service users and their families, people using services and their families. Thank you. That was all I had to say.
Christos, that was fantastic. Thank you very, very much for those insights. So you made 4 key points and then a very important one at the end, I think. One was around policies based on evidence-based policies based on scientific evidence. And I totally second that, and I wish that more countries abided by that. I think it's something that we all need to champion. You talked about professionals training and doctors not being trained, and that's an important thing that we need to get right. You made a really important point, I think, about the balance of power in terms of the patient, service user, client, and the clinician, and spoke as a clinician, which I thought was really interesting, and talked about the balance between service users' rights and then professionals and the risks that they take. And there was a very interesting comment in the chat as you were talking about that, about, you know, sometimes that we need the trust and we need the partnership there. That was coming through in the comments that I thought was really insightful. You talked about the need for cultural adaptation so that the guidance is specific to every country. So otherwise it's not acceptable. And then your final point, I think, was a fabulous one, which was, you know, we all need to be in this together for the greater good of society, essentially, you know, because if we work together, put aside individual differences or perspectives or whatever, we come out with something better together. So thank you very, very much for that presentation. We've got lots of thank yous coming through on the chat. Thank you, dear Dr. Kay, pointing out all that we so often struggle with. Very good insights, Christos, thank you. We've got congratulations to all the presenters. Very important, Dr. Christos, to see the central role of effective therapeutic alliances in driving change. Thank you, Dr. Christos, you're writing History in Greece. The first time the national coordinator is looking and discussing with the community. There was another comment that came through earlier, congrats to Greek peers for an open-minded country drug coordinator. So we've got some really interesting things coming through. We did have a comment on from a fellow Greek, which is we need to address diversion in Greece too. It's defaming OST here. You may want to comment in relation to that.
Give me a second. Sorry, give me a second to unmute.
Okay, okay.
Can you hear me?
Yeah, we can, thank you. So the
Yes.
comment was we need to address diversion in Greece too.
Maybe add a comment on diversion. We've done some work on looking at diversion patterns, and I think it's very important to understand the different types of diversion. Sometimes it's very benign, where drug users are actually drawing people into treatment by sharing their medication, and many of us experienced OST for the first time in that way. Now, we need to be careful not to exclude that from the system, but we also don't want people to give away medication that is very useful to them. But most of us learn quickly to build up some reserve just to keep us protected. Sale of medication is much more challenging, and that undermines the OST system. We've seen in Macedonia, where everybody's selling their methadone outside the clinic, dramatically drives down the credibility of the system. So we see OST Literacy and Rights is about building an alliance together to make sure medication is effectively used. And if you have good access to OST, then diversion doesn't need to follow. That's the key.
Yeah. I think this is a critical point, Matt. You have good access, there's no need for diversion. Diversion develops whenever people don't have access to what they need. Then the challenge is that wherever there is a narrative that opioid prescribing is a continuation of the drug culture, and wherever there are such polarized views, unfortunately, against opioid substitution treatment, there is a shared responsibility of both professionals, policymakers, and people using the substances to defend that and help the rest of the society understand that being on methadone or buprenorphine, whatever opioid substitution treatment, is not the same as using drugs. There is a huge difference. That's why we need to avoid terms drugs when we refer to medications. Semantics sometimes are crucial to change attitudes. And I say that because last night, for 5 hours, I was in a community meeting about the homelessness problem of Athens, and people living out there, the local people were referring to people using drugs as drug addicts, junkies, this, the other, in such a stigmatizing language that obviously had to do with the stigmatizing approach into the whole thing. Take them away, make them disappear. We don't want them here. And sometimes it's easier to change the language we use, ourselves first,
in this unequal struggle in society for our rights and dignity as persons. Together we are stronger, and no one knows better than us what we've been through in terms of stigma and discrimination. So our community is a community of warriors. And I think we've all got a responsibility to try and tackle this stigma and discrimination, and the language that we use, and also how we talk about, very importantly, how we talk about OST medication as medication. It's medication. It's essential medication in many. We have another couple of questions that came through that I'd be interested in terms of the panel's response on. So we've got one from a contributor from the Ukraine who's saying, described a what sounded like a non-evidence-based prescribing regime, and asked a question: how do I raise doctor awareness in terms of the prescribing in terms of OST? So a really interesting point there. And then also another comment that came through, which I thought was interesting, which was, how can we use some of the positive changes that have come from the impact of COVID-19, where in some countries there's been a move to more flexible supervised consumption, less urine testing, and more flexibility of services. So there's a couple of questions there. Christos, can I invite you first to make any comment on those?
Christos K, me.
Christos K.
Yeah. Again, I would approach the question about COVID. Again, we need to look into the balance and we need to know what we have experienced. If by any way the diversion of our medication would be linked to the overdoses and the deaths we have seen, that will be a big blow against OST. If we say that, and we are establishing that lack of access to treatment because of the restrictions of the COVID and so forth, that will be a big win for OST. From experience, because I was involved in global surveys and we've done smaller projects in Greece, sometimes whatever surveys we use does not capture the real problem. And I will say that the major problem in Greece, as I think it happened in other countries, is that COVID exposed the weaknesses of whatever treatment system was there before the COVID. And for example, the major problem that most of the countries had for our people in treatment had that their access to physical treatments for HIV, hepatitis C, or any other medical condition has been really reduced to next to zero. And we're talking here about very, very vulnerable population out there, to the point that there were certain people in Greece that they were on HIV treatment that were not able to access because all the doctors were diverted from the HIV services to staff COVID services.
Over to use as COVID hospitals, and all of the people that were there as patients actually had to leave. So there's been some very interesting responses. Can I bring Dirk? Can I bring you in on this one in terms of COVID?
Yes. Just a second. My camera. Yeah. I know that COVID got very bad outcomes for people who use drugs, but what we see in Germany is that we have a strong increase of patient numbers during the COVID crisis, because the German government, with support also of drug use organizations, patient organizations, and the doctors' organizations, made last year in April some very important changes of the law in Germany, and that's got in June last year more than 2,300 people from the street get into opiate substitution treatment. Also people without health insurance. This is possible during the COVID crisis. And the major goal for us and what we try to do is that these conditions, which show that they are helpful and they are safe, that we keep on going like this after the COVID crisis, and we can implement that in the narcotic law in Germany, that this is also possible after the COVID crisis. And yeah, I know that COVID
external control measures regarding OST in Germany or other countries, meaning respecting patients' rights. And she makes a comment that patients' rights in Poland are commonly undermined.
Yeah, patients' rights are not in the top of the list in Germany, as I can say it this way. We have many examples that the relationship between patients and doctors is not very good. They cannot choose their substance they want to use, and many different things. But what we did in Germany, we tried to implement a kind of contract. All people in Germany who are in OST treatment must sign a contract with their doctor with some regulations and something like that. And we work on a modern contract, also with in the view of people who use drugs. And we try to implement this new contract in the relationship between doctors and patients. It worked, but not all over Germany, only in some regions and some cities. But this could be a way to implement things like that. Also, our project here is a step forward for patients' rights in OST treatment. And but the situation is not good also in Germany, but we work on that it will be better in the future. Yeah.
Thank you very, very much for that insight, Dirk. That's really interesting to hear about that. We've got comments coming through. Go Germany.
Yeah, we try.
Absolutely. We've got something that says similar in I think Nottinghamshire. It took lockdown. We've got a comment, services must be open all day long.
No, it was my mistake, poor typing. Until lockdown 1 ended, where it was how's everybody, it all ended then, and it's gone back to normal now. But community protection officers and police officers carry it, so it's a move forward.
Yes, thank you for sharing that, Lee. So yeah, no, the community protection officers carrying naloxone is a
come into treatment, because actually not having to come every day has been seen as accessible. I know in my area, one disabled drug user has come into treatment, one agoraphobic drug user has come into treatment, all driven by the fears of being caught without drugs during lockdown. However, in the break between the 2 lockdowns in the UK, we saw a worrying trend of drug workers starting to pull people back to defend take-home doses if we start to see pushback. So yeah, please come and join us in that piece of work. And if your country would like the resource, please let us know.
On that, Matt, is there any chance of sort of like including other advocacy organisations? Because in the UK, there's no independent advocacy. You complain to the drug service, they cover for everybody, and the user gets nothing.
Yeah, so one of the things we've found a lot in the UK is that we rarely get acknowledgement of problems. We often get change, but where we force it and it's seen as exceptional rather than as routine. So one thing that Release has very successfully done is they fought a case in the UK for a group of drug users who were on diamorphine. The treatment providers were trying to take it away largely on the basis of cost, not on the basis of personal need. Release fought the case. It was actually settled out of court because they realized they were going to lose. Bearings have now given more money to Release to share that learning, and Kirsty is writing, Kirsty Dowse from Release is writing an advocacy brief that will help UK drug user advocates defend people in OST. So that's a core resource. Chris Hallam is leading on that for EuroMPD. Again, it's a UK funded project, but again, any parts of this that can be adapted and translated, that's the whole purpose of how EuroMPD works.
That's fantastic, Matt. Thank you very, very much for sharing that. It might be worth also looking at the American Association for the Treatment of Opioid Dependence were asked to do a survey to look at the changes in some of the relaxation around supervision largely, and increasing take-home doses in the States. And surprise, surprise, the world didn't fall in when they did this, and actually made people's quality of life better. And I know that ATOD, as it's called, the chair of that, has been championing to keep that relaxation in place there. So I think that there's some movement happening over the water, and that's in a country where, of course, we know it's very litigious, and doctors are risk averse because of the risk of legal action, etc. I just wanted to also mention that in the chat, Matt put up a blog post written by EuroMPD for the UK's biggest treatment provider, and that's Change Grow Live, CGL. And Tony Lee and Matt were invited to present the work to all the prescribers in CGL and offered support to the project. I think we might have Mark on the I work in Kazakhstan on occasion, and I know the situation there needs to improve a lot in terms of OST services. Let's see what else we've got coming through. We've got a comment from Lynn Jeffries. UISCE/Ireland would be interested in a resource on takeaways for sure. So that's great. And we've got, what else have we got coming through? Okay, so I think that's about it in terms of the comments. Let me just check the Q&A. So we've still got the outstanding question from our dear friend in the Ukraine, who's on OST and who wanted to share ideas, wanted ideas on how to increase doctors' awareness. Any of the panel like to
issues where we needed to talk to pharmacists about how to manage these issues, because obviously it caused issues. But even at the highest level, we're now seeing problems with the quality of different OSTs in different countries. And again, that's why we need to be talking to Unitaid. It's why we need to be engaging with different medicines authorities. I think we've started to understand as drug user rights networks that we have to be engaged from the ground right through to the highest level procurement and policy making if
today. Okay, so we're now kind of, if there's any more questions, we've got a little bit of time, or if we're coming to a natural end, we're also happy to finish the webinar. We've got many people needing to go on to different things. So Dirk is leaving us. Thank you very much for your contribution, Dirk. He says hugs from Germany to us all. Hugs back, Dirk.
Yeah, thanks a lot.
Thank you. You were great. Thank you so much for joining.
Thank you.
Thank you
All
very
the best to you.
That's great.
Thank you, Dirk. It was great.
You're wonderful.
Bye.
So maybe just one last thing in there, just to say that if there are countries out there that see any of the resources coming out of this project as being useful to you, please reach out to Christos as the project manager. We would need to put funding together to back this, but a lot of the big funding has already been done. So the translation and rollout, we think there are partners who can support us with that work in country. So please come and talk to Christos, and we can find how to use this project more effective, find out how to use this resource to maximize the rights and health of people with opiate dependence.
That's great. Thank you, Matt. Great. I was just going to say we've got a comment from Mark from CGL saying, thanks for the mention. We're collaborating on an ongoing basis. Our own pulse surveys demonstrated that choices and options are really key in the ongoing provision of see you agains and congratulations, hugs, goodbyes, greetings from Tanzania. Thank you. That's amazing. Thanks, and greetings from Denmark. So we've had people from all over. So participants, presenters, anybody that's just listened or dropped in, thank you very, very much for listening to us. Thank you for your comments. Thank you for any further comments that you want to make. I think this is a really important project. I think the series of webinars will be informative and involve lots of people. So thank you very much to Matt and Euro Input to organising all of this. Thank you to Christos. Thank you to Lee. Thank you to Roberto behind the scenes for helping sort everything out, without whom none of this would have been possible. And
yes, great help from Roberto.
Thank you, Roberto, very much indeed. So I think that we're just about done. So panel, would you like to say any final words or say goodbye to anybody? Christos?
Don't forget to subscribe to the next webinars. There are 3 more. It's every the same day of the week, the same time. And subscribe. We have a wonderful talks with all together.
Thank you very, very much indeed. Lee, any last words from you? Carry a kit and save a life. We can see that. That's great.
Well, yeah, I carry that message anyway and everywhere. People get sick of me talking about the lockdown, but no, amazing that so many people from wide around came and joined us for. I think it's a very important piece of work that should be out there for everyone to read from. You know what I mean? To at least understand, if they don't know how to sort it, they can get in touch with someone. So it's the start of a long road, I think.
Well said, Lee. That's fantastic. Thank you very much, and thank you for your presentation. Matt, final words from you.
Yeah, just to acknowledge, thank you, Christos, for doing all the hard work that put this event together. Roberto, thank you for your behind-the-scenes support, much appreciated. The Euro Input Correlation Partnership